up and watch the hematocrit go up 3 weeks later. I think that's very reasonable. It also doesn't cost very much. Ferrous sulfate is cheap. The studies do cost something. And I think that you have a very good point if you question me on that. And in fact, probably the proper way to do this is to give a woman iron and see what kind of response she gets. And if she has a good response, you've not only treated the problem, but you've made the diagnosis specifically. Now, why do we need to make the diagnosis? Well, we need to make the diagnosis of iron deficiency for a very important reason, and that is there are lots of people in our specialty who spend all their time wondering why it is that certain babies don't come out of certain mothers doing well in the 5th grade class. And you're not going to tell me, because you can't, that iron deficiency, maternal iron deficiency, has nothing to do with this. Now, it doesn't look like it does right now, but we're just not sophisticated enough to know that yet. How do you know that a woman who is not chronically iron deficient and pregnant, or who is chronically iron deficient, will not produce a child who has certain neurologic problems, later on in life? We don't know that yet. Therefore, it's important that we be able to make the diagnosis antepartum and correlate it with reproductive casualty later on. So there are essentially 3 or 4 ways with which you can make the diagnosis of iron deficiency pretty well. The first is the bone marrow. This is probably the best way. Put a needle in the marrow, which isn't all that traumatic if it's done properly. And you take the marrow and you smear it out and you look at it. And if you see this kind of smear, this lady is totally iron deficient. Now, I didn't say she had anemia, but she has no iron stores because the marrow is depleted. And you can compare this slide with something like this, where you see Prussian blue staining of hemosiderin in the marrow. And this is an absolutely characteristic slide of a lady who is iron replete. And this is the difference. And this is how you make the diagnosis par excellence. Now, bone marrows cost a lot of money, and people don't like to stick people in the hip. So what do? We look at peripheral blood smears once in a while. Here's a peripheral blood smear of a patient who was iron deficient. And, if you look at this at first glance, it really isn't all that bad. You see some changes in poikilocytosis and anisocytosis in some of these cells. It's not all that bad. It can get worse sometimes. Here's a lady who had a hematocrit of 20% because she was iron deficient. And now you begin to see the changes I told you about. Here are some cells that have been shot full of holes. I mean, this is hypochromia par excellence. Unfortunately, the quickest way, I guess, to measure this, and I say unfortunately, would be the MCV and the mean corpuscular volume. And you want a mean corpuscular volume which is below 80, let's say. Well, the trouble is that you can have a patient, on occasion, who is both folate deficient and iron deficient, which work against each other in terms of the mean corpuscular volume. The mean corpuscular volume tends to go up with folic acid deficiency. Iron deficiency makes the mean corpuscular volume go down, so you may get a normal MCV when you try and measure it, if both problems are present, as they were in this particular patient. It's better to look at the smear. Here's a nice change in the red cell, the kind of change in shape and hypochromia, if you will, that we see with iron deficiency. Again, more cells. And this happens to be a patient who had folic acid deficiency coexisting, which is not all that uncommon. And you see some hypersegmentation of the neutrophils, which I'll show you further. There's a third way to make the diagnosis of iron deficiency. If you don't want to stick somebody in the hip, you can stick them in the arm again and get a serum iron studies. Now, let me move forward and work backwards here once. This is a plot that was taken from the computer. The computer took all studies that measured serum iron in pregnancy from the middle 1930s to about 1976 and averaged them all out and then plotted them, and that's what you see here. And if you'll notice, the normal behavior of the serum iron, which you really need to know, of course, if you're going to use it for diagnostic purposes during pregnancy, is to go down. It goes down in this fashion. If you happen to supplement the patient with iron, it goes down also, but it goes down at a higher level. And if you don't supplement the patient, it goes down, compared with the non-pregnant and the postpartum state where the serum iron tends to rise a little bit. All right, that's what happens when the serum iron, to the serum iron in normal pregnancy. The total iron binding capacity, on the other hand, goes up. And we're talking about elevation of the protein which carries iron in the serum. And you see, it just goes up in a very nice curve in pregnancy. This is an estrogen-induced effect. The same thing that used to raise the old protein-bound iron in pregnancy, things like that. Now, the question is, if the total iron binding capacity goes up and the serum iron goes down, and the percent saturation is a ratio, of serum iron to total iron binding capacity, can the percent saturation and the serum iron be used for diagnosis? I think it can. If you have a percent saturation of 3 and a serum iron of 5 or 20, if you will, you're dealing with iron deficiency in pregnancy. That's pretty clear cut. But as John Cooley showed a couple years ago, you can't rely on the serum iron if you're in the gray zone. For example, if you have a patient who has a serum iron of 80 and a total iron binding capacity that has also risen and a percent saturation of 20, are you or are you not dealing with iron deficiency in pregnancy? The answer is that more often than not, you are. And I will take, for example, when I see patients in the clinic, I'll take a percent saturation of 23 and a serum iron of 80 and say that this patient is iron deficient, and much more often than not, I'll be right. And in fact, the patient will respond to iron. So really what we're doing is we're really dropping right back again to treating this patient with therapeutic doses of iron in pregnancy and seeing what happens to make the diagnosis. For those of you who need academic ways, something to hang your hat on to correlate reproductive casualty, these are the diagnostic methods you can use. There is a fourth diagnostic method, which is probably going to be more important as time goes on. And that's the only reason I mention it, not because I want you to all go out and get serum ferritin levels, but because it's just being studied. And in fact, it's only been in the last 4 or 5 years that ferritin, which is one of the binding complexes of iron, has been recognized in serum. And so that you can actually draw blood and measure serum ferritin and see if it's low. This may be, in the future, an extremely sensitive form of making the diagnosis of iron deficiency in pregnancy. And I mention this because as time goes on, you will probably run into this. In Atlanta right now, in fact, you can get a serum ferritin level, if you so desire, in pregnancy or not in pregnancy. It costs the patient about $25. And I personally would not like to do this yet because I don't believe that the studies are enough with ferritin in serum in pregnancy to give us the kind of behavior graphically like we see with the serum iron and TIBC. I want to know what the serum ferritin is like in normal pregnancy at 32 weeks, if you will, before I start saying that this patient is iron deficient, as with all other blood studies that we get in pregnancy. So I bring that up for the future, and you might be interested to watch the progress of the serum ferritin. Well, time is getting short, and I think we need to move on to the rest of the nutritional discussion. I'm going to talk about folic acid, as I've said before, for 2 reasons. The main reason is you need to know why your multivitamin pill contains folic acid. You do. You need to be able to defend it. Just the same as you can defend taking all the other junk out of the multivitamin pill, you need to know why the folic acid is in it. And secondly, I know something about it, so I guess I ought to talk about something I know about. But really, you need to know about folic acid because we're going to refer to this constantly 2 weeks from today when we start talking about diseases which will affect folic acid metabolism in pregnancy profoundly and cause profound anemia if you're not careful. Folic acid is a disease, folic acid deficiency in pregnancy is a disease that is much like Rh disease. You know, Rh disease was really discovered in 1940. And then then it went through various diagnostic steps till 1968, where everybody pretty much had a handle on it. And then the people in New York came out with prevention, and finally we're back again to where we started, where it's a disease that's been discovered, diagnosed, treated, and prevented. And now we're back to where we're really knocking it out of the obstetric picture. Well, it's the same way with folic acid deficiency. Folic acid was probably first recognized in the late 1930s. In the 1940s and 50s, everybody in the world had folic acid deficiency. Okay, everybody was pregnant, and it became very popular. In 1945, this compound was first crystallized in one of the drug companies here. And in the 1960s, the British picked up on folic acid deficiency and decided that everything in pregnancy, prematurity, congenital anomalies, sneezing, stuffed up nose, all due to folic acid deficiency. I'm not really exaggerating. You ought to see the list that was published in the mid-1960s. And finally, as the 1960s wore on, some internist, mind you, had the gall to write to the New England Journal of Medicine and say, well, look, if all these people have folic acid deficiency, how come all you drug companies only have 5 preparations in the whole PDR that contain folic acid that are meant for prenatal use, and the other 25 don't? And so, of course, overnight, all the drug companies decided that maybe we better put some folic acid into the prenatal vitamins, so they did. And now, as far as I'm concerned, the disease is back where we started from. It's totally prevented. By giving 1 milligram of folic acid a day, you can prevent folic acid deficiency in 99.9% of cases, no matter what the lady's problems are. For those of you who like biochemistry, I will tell you that this is the molecule of folic acid, and this is the kind of thing, when you prescribe it, the pharmacist gives out this stuff. This is the molecule with the little r on the end, where a bunch of glutamic acid residues are attached. Now, this is pteroyl glutamic acid, which is in the 1 milligram pill that the pharmacist dispenses. In green leafy vegetables, peanuts, lettuce, kidney, liver, foods like that are high in folate content, what you find is that the R position on the molecule contains a number of these glutamic acid residues that go all the way out. This is kind of important clinically, because if we talk about the effect of oral contraceptives on folate metabolism, we need to know that this molecule, with all the glutamic acid residues, is the kind that is present normally in food. And when you take it into the intestine, a conjugase in the intestine splits off a certain number of these glutamic acid residues and makes the molecule ready to absorb. Now, this is probably the point where oral contraceptives, for example, interfere with folate absorption. And we know that because if you have a patient who is folate deficient who's taking oral contraceptives, you can give this molecule, which is the pharmacologic folic acid, and not stop the oral contraceptives, and the patient will remit immediately from the disease. So I think that biochemistry part is a little bit important, and I guess this is too. It's hard to see, but the rate-limiting step in DNA synthesis is right here, formation of thymidylate, which requires a cofactor of folic acid, and this is what causes all the darn trouble in folic acid deficiency. This is why this compound is so basic to pregnancy. In the formation of DNA, when DNA is being formed, this cofactor of folic acid must be in adequate supply. If it is not, DNA does not stop being formed. What happens is the rate of DNA formation slows down, and that produces some very interesting findings. Basically, the findings that it produces are dysplastic cell changes in every organ of the body. Perhaps not the brain, but every other actively growing organ of the body. The cervix, the bone marrow, peripheral blood, so forth. And this is because the nuclear cytoplasmic ratio changes, and these cells take on funny shapes. Not only do they take on funny shapes, but in the marrow, where megaloblasts form, which are simply dysplastic red cell precursors as a result of folate deficiency, in the marrow, these precursors form and they break up. Body doesn't like them. So you have intramedullary hemolysis. Red cells have a tremendous content of LDH, and as we'll see, the LDH rises tremendously in pure folate deficiency because of this factor. Little biochemistry goes a long way. This is the graph, my favorite graph, which shows how folic acid deficiency rapidly became a disease. It came into its own very quickly. Not because it hasn't been around, it's just because everybody jumped on the bandwagon. If you look for the disease, you'll find it. And in fact, where it took 1 in 250 confinements back in 1955 to find one case of folic acid deficiency, as we approached 1970, it took 1 in 30 or 1 in 50 confinements to find the disease because everybody was looking for it. Hasn't really increased. Now, why do you get folic acid deficiency in pregnancy? You get it because you don't eat right. The hospital diet at Grady Hospital, I hope, contains 150 micrograms of folic acid per day. That's rough. The minimum requirement for folic acid, daily requirement for folic acid in a non-pregnant woman is about 50 micrograms a day. Pregnancy, that jumps to about 10 times, at least 10 times, maybe more. You got to take it in, right? That's the source if you're not supplementing. I don't know about this, and I'm just going to pass over it. As far as defects in utilization and metabolism, there are certain rare situations where this can occur. For example, the administration of anticonvulsants to epileptic patients. Dilantin and other anticonvulsants will interfere to some extent with folic acid metabolism. I guess you need to know that in our epileptic patients, because if a patient who is pregnant, who is epileptic, who is on an anticonvulsant, suddenly develops further seizure activity for which you are at a loss to explain, she hasn't hit her head or anything like that, consider in the back of your mind the possibility that she may be developing folate deficiency. Don't go out and get a hematocrit to try and prove that, and you don't even have to get an erythrocyte folate level. Put her on adequate folic acid. Find out if she's taking multivitamin pills, basically. That's the way to handle that, and then adjust your Dilantin accordingly. Finally, the most important cause of folic acid deficiency in pregnancy is increased demand. The trophoblast and the fetus need folic acid to live. If you got twins, you've got a bigger need for folic acid. It stands to reason. Closely spaced pregnancies, the maternal deprivation syndrome that some people are fond of talking about, And grand multiparity can contribute to this. And of course, the presence of associated conditions such as hemoglobinopathies with hemolysis, which is what we'll talk about next time. That's the most important cause, to show you that diet is a problem. Here's one situation where 200 patients were studied in a clinic setting, and 25% of them, just on asking the patient what she ate and adding up the folic acid intake, were either frankly deficient or really short of folic acid in the diet. So diet really is a problem. We had a patient in this hospital not too long ago who we computerized her dietary intake of folic acid, and it was 6% of the recommended daily allowance, whatever that is, for pregnancy. And in fact, she came in with a hematocrit of 16% and obvious megaloblastic marrow and so forth. The dietary intake is of importance. This horrendous slide, I've got a few of them, I'll tell you. This one shows what happens, why increased demand is really so important. And all you got to do is just look at the middle of the slide, never mind the numbers. This yellow line here represents what happens to fetal growth in the last half of pregnancy. This is the most rapid growth curve time of the baby, from 20 to 36 weeks, if you will, or 22 to 36 weeks. And you'll also notice that this is a plot of the serum iron in otherwise normal pregnancy. And you'll notice that if this is a normal level of serum iron, right about here, that at about 36 weeks, the serum iron normally falls to low levels in otherwise normal pregnancy. And finally, these circles represent, if you look at the literature and plot when in pregnancy cases of folate deficiency were discovered, you find miraculously that the vast majority of cases of folate deficiency were found in the late third trimester. Well, now you have an explanation for that in terms of increased demand. Fetus is growing, needs it. Serum iron goes down, biochemical evidence that folate is being used in the pregnancy. And finally, look where all the cases occur. They all simultaneously reach a maximum right about here, which is why folate deficiency used to be called pernicious anemia of pregnancy. Don't ever mention that. Pernicious anemia is a disease of 50-year-old gray-haired ladies who come from Scandinavia and are B12 deficient, okay? It is not a disease of childbearing age women who are pregnant. And in fact, those of you who are aware of this know that people who are vitamin B12 deficient with true, if you will, pernicious anemia, who are in the childbearing age, don't get pregnant. And there is a certain amount of infertility involved with this. This comes about as close as I can find to a specific nutritional defect causing a specific form of reproductive casualty, i.e. infertility. If you treat the vitamin B12 deficiency in these people, as an aside, they may get pregnant. It's kind of interesting. We just don't see that many cases of true pernicious anemia in the childbearing age. I'll mention this because we do need to know why we get diagnostic tests in pregnancy for folic acid deficiency. Again, folic acid deficiency develops in a very orderly fashion, as Victor Herbert showed many years ago when he made himself folate deficient and bone marrowed himself once a week and drew blood from his arm once a week and ate gumdrops and thrice boiled food and stuff like that. He had a good time. Kept a diary, supplemented himself with iron. Said his wife didn't like him this week, stuff like that. I don't know if that's because of the folic acid deficiency or because his wife didn't like him. But he went through all this, and he plotted it out beautifully. I mean, this is a beautiful demonstration on himself. The first thing that happened was the serum folate fell. He's still not anemic, okay? Second thing that happened was he got hypersegmentation of neutrophil nuclei in peripheral blood, if you will, the lobe average, if you quantitate that. All these tests occurred. Notice low folate in erythrocyte occurred at about 16 weeks. Finally, as the last thing that happened, mind you, just like in iron deficiency, anemia began to develop. So once again, it is possible to be folate deficient, not be anemic. In other words, you can have biochemical evidence of folate deficiency. And this is where the oral contraceptive story comes in. If you go for a year on oral contraceptives, a certain number of people will be found to be biochemically deficient in folic acid, but will not have true overt folate deficiency as evidenced by dysplastic cell changes. So we take advantage of Dr. Herbert's beautiful scheme to make the diagnosis of folic acid deficiency in pregnancy. This is the simplest and cheapest way. Get your laboratory technician to smear out a blood film and go look for peripheral blood neutrophils and be a nucleus counter, 1, 2, 3, 4, 5, 6, 7, if you will. And that's a hypersegmented polymorphonuclear leukocyte. And if you count up 100 of these and divide by 100 to get what we call the lobe average, if it's above 3.62, you have true hypersegmentation. And in pregnancy, that is almost absolutely specific for folate deficiency. And it's very simple, costs next to nothing, it's early. Iron deficiency that's severe can sometimes do this, but call it folate deficiency until proven otherwise. That's kind of easy. Here's another one, you know. I'm fond of looking at those things. If you want to see what happens to the lobe average in a controlled study, this is the lobe average in otherwise normal non-anemic pregnancies, and this is the lobe average in folate-deficient pregnancies proven by other means. And you can see there's quite a difference, so that the specificity and sensitivity is pretty good of that simple test. You know, it's nice to have simple tests once in a while. I had to, you see, look at that, all right? Take a good look at it. Okay, now what we're going to do is we're going to plant the atom bomb, we're going to blow it apart, see what happens. It's a little better, not much, okay? But the purpose of this slide is to remind me to tell you what kind of abnormalities we see in folic acid deficiency biochemically. And you should know this because some of these abnormalities are quite important in the diagnosis and treatment of toxemia pregnancy, which I'll get to next time. It's a favorite subject of mine. It's quite interesting. These people will develop intravascular hemolysis and show a lot of these signs, so they're important to recognize what's happening. If you treat a lady, this patient had a hematocrit of 16%, if you will, at 36 weeks. She had a positive RPR and sickle cell trait, both of which are not related to her current problem, and marched in the hospital with having received approximately 100 cc's of Inferon from one of our local clinics here in Atlanta, because they couldn't understand why her hematocrit kept dropping, despite the fact that she got all this parenteral iron. Therefore, they knew she got the iron, but her hematocrit kept dropping and dropping and dropping. It got to 16%, and the lady couldn't stand up, and her tongue was a little sore, and she marched in here, and we had some fun trying to take care of her. Now, this is what happens. Folic acid deficiency is important, despite what the British said in the 60s, for only 3 reasons. Number one, it produces anemia. Number two, and it can be profound. In fact, it's the most profound anemia other than sickle cell disease that we see in pregnancy. Number two, it produces thrombocytopenia. This is what happens when you treat folate deficiency. Look how the platelets come right back up really quickly. Very nice. That's only after about 2 weeks of therapy. A beautiful, quick rise in the platelets. The reason thrombocytopenia and anemia as direct consequences of folic acid deficiency are important is because just about everybody who comes to term with thrombocytopenia and delivers, and the thrombocytopenia is caused by folate deficiency, bleeds. Okay? It's, in the literature, it's practically close to 100%. The platelets are not only less, but they're defective. I mean, why can't this dysplastic cell maturation affect platelets as well as red cells? It does. No question about it. So these platelets don't function well as being reduced in number. But if you get on the patient, you make the diagnosis and treat it, look how fast you can bring that thrombocytopenia up. And that patient won't bleed. In fact, this lady didn't. Her hematocrit went from 16 to 32, after decent therapy and so forth. Here's the LDH somewhere that I was talking about right here in folate deficiency. Look at how the LDH drops dramatically as you treat the deficiency state. The quickest rise in anything that occurs following administration of folic acid to a folate deficient anemic lady in pregnancy is the reticulocyte count, which just shoots up in about 48 hours. And, it's not uncommon to see reticulocyte counts of 30% on recovery in these people. But at the same time, the LDH drops dramatically as red cells stop breaking up in the marrow and begin to go on to normal lines of maturation. The lobe average, represented by these bars over here, drops as you treat the folate deficiency, as you would expect it to. And finally, I guess the most important thing, of course, is that the hematocrit, look at that, that's up to about 32. Way down here, it's a dramatic rise that you can get. Never give up at term on a folate deficient patient. All she's got to do, if she comes in severely anemic and you prove the diagnosis, all she's got to do is go 1 week past term and you'll have her in a perfectly normal range with normal platelets and you won't have any problems. So that finally the third consequence that's proven of folate deficiency is an increased risk of transfusion therapy. And that you avoid by, of course, getting rid of the anemia and thrombocytopenia. That's what dysplastic or atypical cells from the cervix can look like on a pap smear if you have an obvious folate deficient patient. That came from this patient, by the way. This can happen. You can get an atypical or mild dysplasia reading on a pap smear. Now that I've said that, forget it. I mean, you get atypia or mild dysplasia. I mean, you work the patient up the way you're supposed to. Never mind the folate deficiency. But keep in the back of your mind that that's possible. Sure, why can't the cells of the cervix become dysplastic? Look at these nuclei here. See how big compared to the cytoplasm? And those of you who are really sharp-eyed can see a hypersegmented poly in the background over here in this patient. And then finally, if you treat the patient after 7 to 10 days, the smear begins to revert to normal. Notice the lower size nuclei compared to the cytoplasm in the pap smear. Babies from folate-deficient mothers, like an iron deficiency, seem to do all right. Okay, if you plot them out on the graph as to where they ought to be at term, they all seem to fall into a decent range. But, as you know, and as Dr. Freeman will tell you and so forth, and this is the grossest measure of whether a baby's all right. So they have a fine birth weight. So big deal, again, what are they going to be like in the 5th grade class? And I think we need to find out about that someday. Complications of folate deficiency, this is kind of interesting. Foods that contain iron also contain folic acid. So then why can't you be deficient in both, have a dimorphic anemia? And in fact, when you look at our hematology clinic patients, I'll be darned, but 42% of the people who were folate deficient were also iron deficient. Getting back to that lady that got the 100 cc's of Infron, of course, the reason she didn't respond anemia-wise was because she wasn't treated with folic acid. But when she was treated with folic acid, the most amazing thing happened. Serum iron plummeted down because she was still iron deficient despite all that Infron. And then when she was treated with folic acid, iron now became the rate-limiting factor in erythropoiesis. So she had to be put back on iron. And then she did fine. Well, I'm going to quit here, and I guess if we have any time for questions, fine. This sign was given to me by some of my Schlockmeister nurses one day, and it still hangs on my wall in my office because I enjoy it. Those of you who know French, si le père a fait l'entrée, nous obtiendrons l'enfant. That's fantastic New Jersey French, which basically says, if Dad got in, we'll get the baby out. That's the motto we used to have. Now we don't use that motto anymore for. As obstetricians today, we're not concerned with arms and legs on kids, or at least we shouldn't be. We don't give drugs to people in pregnancy. Dr. Winnick in New York, one of our really good nutritionists, loves to say, when people ask him, well, why don't you give megadoses of vitamin C in pregnancy? Well, aside from the fact that he's found a couple of cases of intrauterine scurvy, his classical statement is a good one. He says, well, if you're going to give huge doses of vitamins, you're essentially giving a drug, aren't you? You're giving pharmacologic doses. And you don't give a drug to a pregnant woman if you can help it. So we shouldn't be concerned. We don't give drugs to pregnant ladies if we can help it. Therefore, we shouldn't be concerned about whether the fetus has arms or legs, any more like that nonsense. What we should be concerned about now is whether the baby's neurologic development someday will be good. Thank you.
I seem to have wasted 20 cents on a Coca-Cola.
Thank you.
I just wanted to know how much it was. There is time for questions, and the floor is open, please. Dave, we've talked about this in private and semi-private many times, but does it seem strange to you that women have been able to have pregnancies delivered for the last 5 million years, and SmithKline & French has only been in business making Fiasol for about 50 years. You and I have also agreed we know why that is, but maybe you might say something.
Well, I think that I'm sorry, I'm glad you mentioned Fiasol. I like the one with the little dots in it.
Yeah.
SmithKline & French, forgive me, throw that out, Just, you want to supplement a patient with the cheapest and best preparations. You give her ferrous sulfate, And if you want to talk about intolerance, we can talk about that too. But basically the answer to this question, as far as I'm concerned, is that women did not deliver babies properly for the last 5 million years. I mean, medicine made some advances. Even in obstetrics, we've made some advances, And I think that probably women didn't. Women were iron deficient. Women died because of anemia, severe anemia. In fact, 20% of maternal mortality in India today is because of anemia as a direct